there'll be a little bit of overlap with what Monisha spoke about, but this is something which is of interest to most of us. And I'll just try to walk you through how does a lens contribute to angle closure disease and what's a rationale for clear lens extraction, and maybe speak a little bit about what the evidence is in this regard today. So when we looked at our population-based study, we looked at about 2,000 odd patients and looked at their biometry. And we divided them into 10 equal groups based on increasing axial length, AC depth, and lens thickness. And this is what we found with axial length. And this is what you would expect to see, that the shortest eyes have the greatest risk of angle closure. Almost 70% of them had some form of angle closure disease. But as was alluded earlier, myopia does not mean that you are not at any risk. Even among the myopes, you had a small proportion who had some form of angle closure disease. When you look at anterior chamber depth, that becomes even more exaggerated. The shortest, the narrowest, the shallowest eyes had very, very high risks of angle closure disease, and the deepest much lower. But when you look at lens thickness, the whole thing gets a little wonky. The thickest lenses definitely had higher risk of angle closure, but that risk was sort of distributed all over the place. And why is this? This is because if you take lens thickness in isolation, it doesn't really make sense. So what you need to do is you need to take this in the context of the patient's axial length and of the patient's anterior chamber depth. And this is what is called the relative lens position. And when you modify it like this, it goes from looking like this to following the same component. So thinking about the lens in isolation is problematic because in isolation it doesn't really mean anything. If you have a big lens in a small eye with a crowded anterior chamber, it is going to cause a little bit of an issue. If you have a big lens in a long eye, it really doesn't matter. So when you look at this quantitative evaluation of anterior chamber parameters using the AIOS2025 to detect primary angle closure mechanisms. So what they did is they looked at AIOS2025 images, and based on that, they tried to define what was the reason for the angle closure. And they divided it into pupillal block, plateau iris, a thick peripheral iris roll, or an exaggerated lens vault. So they did an AIOS2025 to try and figure out which mechanism they could identify by this. And they obviously took all the other measures, and just to remind you that the lens vault is the area of the lens which is in front of the line which joins the two scleral spurs. And what they found here was, in about 33% of patients, an exaggerated lens vault was the reason for the angle closure. So about a third of eyes, they found that it was a lens which was possibly the most important angle closure mechanism. A similar study was done in an Iranian population, and here too you find about 25% of patients, an exaggerated lens vault was the reason for this. When they looked at the changes in AIOS2025 parameters after LPI in Caucasian eyes with different primary angle closure mechanisms, what you find again is the eyes with a large lens vault, very few numbers, but they were significantly different from the eyes which had the pupillary block or plateau iris or the thick peripheral iris configuration. And when you look at the parameters that were before and after laser peripheral iridotomy, actually they found no difference in the parameters in either of these groups. So it did not really seem to matter which type you were. The anterior chamber deepening did not change between these groups, but keep in mind that the number of eyes with thick lens vaults was very small in this group. So look at a Polish population. Again, you have a large lens vault in about 17 to 35% of the population. I really could not find anything from India. And we know that Indians actually behave a little differently from the other Chinese eyes in terms of the way angle closure behaves. And this paper from Tin Wong, which is a little old, but it's in a population with significant numbers of Indians, Chinese, and Malays. And you find that the Indians and Malays have actually much lower rates of acute angle closure as compared to those of Chinese origin. And when you looked at this study, which is again from Singapore, and you look at the different angle closure mechanisms, and you subtype it by race, you find that there are maybe about 20 Indians in there, and none of the 20 Indians had an exaggerated lens vault. So most of the exaggerated lens vaults were seen in the Chinese actually. Even the Malays had very few. So this seems to say that this lens vault mechanism, which has been reported repeatedly from East Asia, may not be as prevalent in Indian eyes as we think. So is the lens a culprit in all PSCG? Really not. In India, what's the number? Is it 20%? Is it 10%? Is it 5%? We don't know. How does it change post-YAG LPI in these eyes? We don't know that information either. And that's really the information we need to know before we make any decisions on what to do with the lens. So we were hoping that this study will tell us what happens to the angle post-LPI and whether this really helps. And so this is, of course, the EAGLE study, which Monisha also alluded to. And essentially what it did, it looked at primary angle closure above 50 years, or primary angle closure with at least one intraocular pressure more than 30 millimeters of mercury. This is one little bit that everybody forgets about conveniently. You had to have a pressure of, at least one pressure of more than 30 millimeters of mercury. You had to have at least 180 degrees of appositional or cynical closure. And what did they find? They found that the quality of life was marginally better in the patients who had a lens extraction. There is a reason for that, which I'll come to a little later. And they found the intraocular pressure was less by about 1.2 millimeters of mercury. So not a huge difference, very, very marginal differences. And from what Sanjay just told us, that 1 millimeter is within our measurement error. And when you look at all these factors, I mean, these are basically the quality of life, and these are the intraocular pressure levels. The moment you subtype it, you actually find that none of them actually cross significance. Within the subgroups, there's nothing that crosses significance, and that's a concern for us because based on this, people are advocating a clear lens extraction. So is a clear lens extraction a remedy? Definitely not for all. The lens is not a major contributor in the majority of eyes with angle closure. It may have a role in a small number of eyes after a YAG PI. If you have persistent narrow angles, if you have increasing sin K in spite of a YAG PI, and you have uncontrolled intraocular pressure, in which case you might want to combine it with a glaucoma procedure just to reduce the risk of aqueous misdirection in the postoperative period. But this number of eyes is fairly small. And at this point, really speaking, clear lens extraction does not have a huge role in treating angle closure. Thank you.
Thank you so much for providing